Hello, thanks for joining us tonight. I'm Dr. Michael Lersten. I'm the interventional pain physician with Panorama Orthopedics.
I'm Dr. Todd VanderHeiden. I'm one of the spine surgeons here at Panorama Orthopedics and Spine Center. We have a big spine team, and it's kind of divided up into two groups, the non-operative specialists and the operative specialists. We have 6 talented surgeons, and I'd like to consider myself one of them. I think we have a lot to offer our patients, and I believe we help a lot of people.
Tonight, we're going to be talking about 2 of the most common presenting symptoms that we see in clinic, and I'm specifically going to be talking about 2 of the most common causes of those symptoms. I'm going to be speaking to you as I would if you were a patient in my clinic and we were trying to figure out what was generating the symptoms that you're seeing me for. In order to understand the potential generators of symptoms, we need to understand the anatomy of the spine. One of the most common presenting symptoms that I see is pain in the back. This can be presented as a backache. This can be the back catching or locking up. And to understand what can cause back pain, we need to understand the structures of the spine. And I think of the spine in 2 distinct parts. The anterior or front portion of the spine, which is made up of vertebral bodies, the bony portion here, and the intervertebral disc here. The posterior portion of the spine is the roof of the canal that protects the neurologic tissue. It's also made up of these spiky, bony prominences that are where muscle and tendon connect. And it also has these small joints that we call facet joints in the back that allow for rotation, flexion, and extension, which is leaning back. These small joints in the back are like other joints in the body. They have cartilage. They're contained by a tight capsule. It's like you can imagine like a tight rubber band that keeps it self-contained with fluid. And these can wear down and become arthritic, just like your knee or your hip. When a patient comes to me and they describe pain that is in their back, that's in the same location consistently, has a dull, sore, achy quality, and is often worse when they stand or walk and improves when they sit, one of the most common pain generators is the facet joint in the back. These joints are innervated. They can cause often dull, sore, achy pain that makes daily activities like vacuuming and even just moving around or walking for extended periods of time difficult. This kind of pain typically stays in the same location. Patients are able to clearly identify where that pain is, and it occurs repeatedly. There's physical exam maneuvers that I can perform in clinic to verify this joint as the pain generator. And when put together with your history, often it becomes quite apparent that we've identified the correct pain generator. My next step is to determine whether advanced imaging, like an MRI, is necessary, which can give me information about which joint or joints, as more than one can be involved, may be causing the pain. Our treatment of facet arthropathy or facet joint pain in the back starts, as many things do in spine care, with physical therapy. I often emphasize it's important for patients to understand that physical therapy often does not provide short-term pain relief, but is critical for long-term care of the spine and improvement not only in strength and posture, but in how you move in a way that's healthy for these posterior spinal structures. In the short term, while you're dealing with pain that can be limiting in therapy in your day-to-day life, there are 2 specific treatments that I can offer in the short term. And that is an intra-articular steroid injection in which I can use live X-ray to take a small spinal needle into the facet joint in order to deliver medication. And that steroid medication reduces inflammation, over a course of 2 or 3 days to a week and can provide long-lasting decrease in pain, allowing an improvement in your day-to-day function, as well as increased activity with therapy for long-term improvement. These two approaches together can provide powerful long-term treatment for a common presenting cause of low back pain. The second symptom that I see quite often is leg pain. This is typically thought of as sciatica or shooting electric shock type of pain down the leg. Now, although this pain is felt in the leg, it can be a spinal issue. I mentioned earlier the spine is thought of as a front or anterior portion and a posterior or back portion. The anterior portion contains the intervertebral disc that can be thought of as kind of a tire type of a structure. Very tough on the outside, willing to withstand many forces without breaking down, much like a tire. The inside is filled not with air, but with a toothpaste type gel material that functions to distribute force along with the bone through the spine. Now, tires can change over time. They can lose air, they can change shape, and this can happen with the vertebral disc as well. That is not necessarily pathologic, and one of the important points in coming to see me is to determine whether changes in the spine are causing symptoms or not. If they're not, we call those incidental findings in the spine. Now, in addition to losing air and changing shape, the disc can also spring a leak. You can get a flat tire type of an injury in the spine. That's represented by this small red portion on the model. Instead of losing air like a tire, you lose some of the gel-like material from the disc that the body then needs to clean up. In cleaning up that material, an inflammatory response is produced. Much like if you got a cut on your finger and it becomes red, inflamed, tender, that kind of inflammatory process occurs so the body can clean this disc material up, which is good. The issue is during that process of inflammatory cleaning, the nerve, which exists and exits out an opening between the anterior and posterior or front and back portions of the spine, can be irritated. This nerve innervates the lower extremity and when irritated can produce shooting, electric shock, burning type of pain that's commonly known as sciatica. We call this radicular pain, radicular meaning root. So the issue often in a shooting, severe leg type pain can be a herniated disc in the spine, or it's easy to think of it as a flat tire in the spine with that leak irritating a nerve. This is a painful, albeit usually temporary condition that generally resolves within 6 months. Physical therapy, once again, is an excellent initial treatment starting point, although once again, it does not treat short-term pain, but is an investment in your long-term health and mobility of the spine. The way you move your spine is critical and is the function of physical therapy. In the meantime, in order to treat your pain, in addition to medications, which can help reduce the symptoms somewhat, a powerful interventional treatment is known as a transforaminal epidural steroid injection. This is a delivery of steroid directly by the irritated nerve and the herniated disc, or leakage of material that's inflaming that nerve. The foramen is the opening the nerve comes out. Transforaminal means that I deliver a needle using live fluoroscopy through the opening where the nerve comes out, where steroid is delivered, coating that nerve and reducing the inflammatory, painful symptoms that are often experienced in the leg. So that's an overview of two of the most common presenting symptoms I see in clinic and two potential interventional treatment options to help with symptoms. It's important to understand in some patients, the degree of symptom improvement may be insufficient. The duration or length of symptom relief may also be too brief, and further, more aggressive, definitive treatment may be required. In that case, Dr. VanderHeiden, my colleague, can discuss in more detail surgical treatment options.
So one of the main things that I see as a surgeon of the spine are disc herniations. So disc herniations occur when the cushion between the bones bulges out and starts to pinch a nerve. And when the nerve is pinched, it can cause pretty severe nerve pain down the leg, leading to a condition that we would typically call sciatica. Sciatica is a term that simply means painful sciatic nerve. And the sciatic nerve, it's kind of like an upside down tree. And the roots of the tree are in the spine, and then the trunk goes down the leg. When a root is pinched in the spine, the entire trunk can hurt. And this can cause severe pain down the leg. And it usually manifests as a burning, shooting, numbing, tingling, or any combination of those symptoms. The good news is the vast majority of those sciatic situations go away on their own, and there's very successful treatment with non-surgical measures. However, there is a select percentage of those that ends up going on to surgery. And what I can do as a surgeon is take the pressure off of the nerve. And the way that we do that is by removing the disc hernia. So the disc hernia has been compared to things like a jelly donut or even a ding dong, the cousin of a Twinkie. So the jelly, when the jelly comes out of the donut and herniates into the spinal canal, sometimes it pinches a nerve. And as a surgeon, I would take that disc hernia or the jelly off of the nerve, and usually the nerve breathes a sigh of relief and the nerve pain goes away. The way that we accomplish that surgery is through what we call a minimally invasive approach. So the minimally invasive approach, as the name would suggest, is through a small incision working under a microscope through a less traumatic type of surgery where we take that disc hernia off of the nerve root, and then the sciatic trunk tends to feel a lot better. So that's one of the main things that I see in clinic. Patients who have not gotten better from their sciatica, they continue to have problems even after conservative treatment has been tried. They may have even had an injection of cortisone around the nerve to try and calm it down. And when all that fails, folks tend to find their way to me, and as a surgeon, I believe I can help by removing that hernia. So that's one of the main reasons we do surgery. The nice part about that surgery, it's minimally invasive. Patients get to go home the same day, and it's been shown to have incredible results. Most patients experience near complete recovery. The second main problem that I see in the clinic as far as the lumbar spine is concerned is what we call stenosis. So stenosis is simply a term that means narrowing. So the spinal canal becomes narrow, and then instead of one nerve being pinched, many nerves become pinched. And the symptoms that stem from that problem typically involve less sciatic pain and more just fatigue and a sense of weakness in the leg with walking. Patients' symptoms tend to manifest when they're trying to walk a certain distance, and their legs get fatigued and they're required to sit down. One of the most common scenarios for this is when patients go to the grocery store, they find that they can walk a lot further because they're bending over, leaning over the grocery cart. That position tends to allow the patient some resolution of the symptoms because that bent forward position allows more room for the nerves. And then when they try to walk around the block or around their home, they tend to get those symptoms to recur because they're standing more erect, and that imparts more pressure on the nerves. So that stenosis, or what we call narrowing of the spinal canal, is something that we frequently see. It's not an urgent condition, but it is a condition where patients can certainly benefit from surgery. The purpose of the surgery is simply to take the pressure off the nerves. And in comparison to the disc hernia surgery, where we're taking that gelatinous portion of the disc, or when the cake and filling come out of the ding dong, we take that off the nerve. In this case, we tend to remove other anatomical structures that are pinching the nerves. Common ones include bone spurs from arthritic joints, thickened ligaments, and bulging discs, which are slightly different than disc hernias. But the point of this is that we are making the spinal canal bigger. We're enlarging the spinal canal to make more room for the nerves. That procedure is what we call a decompression. That's kind of the more general term. The more focused term would be a laminectomy. So the lamina bone is some bone that covers the nerve canal, and in order to enlarge the nerve canal, we remove the lamina bone, hence the term laminectomy. So that procedure can often be accomplished through minimally invasive means as well. Occasionally, we have to remove more bone spurs and ligament and joint in order to enlarge the spinal canal. And sometimes because of that, the stability of the spine is compromised. When that occurs, it is sometimes needed to fuse the spine together. And that's done in order to provide stability. Modern fusions typically involve placing screws and rods. The screws are placed into the bones to provide bony anchor points for stability, and then those screws are connected with rods, which essentially connects one bone to the next. But the hope is that we could avoid a fusion in our patients and get the nerves decompressed and allow resolution of their stenosis symptoms. Patients tend to be able to stand straighter and walk further distances. So just to review, we've already talked about disc hernia and disc hernia surgery, and the second one was stenosis, or decompression type surgery. The third most common thing that I see in my clinic is what we call a slip, when one bone slips forward relative to the other. The medical term for that is spondylolisthesis. It's a complicated thing to say, but it simply means that the bone above has slipped relative to the bone below. That's a situation where the stability is compromised. That tends to result from a combination of factors. Usually it's a degenerative condition that occurs over many years, and the culprits are usually a degenerative disc and two degenerative joints. We call those joints facet joints, and Dr. Lersten spoke about those items. When the joints and the discs become degenerative, they can become somewhat incompetent as far as providing stability. With that lack of stability, you can get a shifting of the bones. And when the bones shift, it tends to cause back pain, but it can also lead to pinching of the nerves, or stenosis. That's another cause for stenosis. So instead of large bone spurs or thickened ligaments or bulging discs, in this case, the slippage of the bones can lead to pinching of the nerves. In that case, The surgery to treat it is to realign those bones, realigning the bones and providing stability through a fusion. And as I described, that entails placing screws and rods and bone graft. The bone graft is where the fusion occurs. That's when the bones grow together. The screws and rods we call fixation. Fixation is when we provide the scaffolding or the internal brace for the spine to provide immediate stability. So when we provide that fixation and fusion after realigning the bones, the spine is now stable, the pressure is off the nerves, and patients tend to experience not only improvement in their back pain, but also in their pinched nerve type symptoms, whether that be the sciatica or the stenosis type of symptoms that I described with the fatigue and the sense of weakness and the inability to ambulate longer distances, those types of symptoms. So that's the third most common thing I see in my clinic. That surgery I would call a realignment and fusion. That surgery can be accomplished through minimally invasive means where we make small incisions, work through a microscope, realign and stabilize the spine. Sometimes it's required that we do a midline incision, a little bit bigger incision, and open the back in order to accomplish those goals. Either way, patients tend to have a significant improvement in their symptoms, not only of back pain, but the symptoms in the lower extremities related to the nerves. The fourth most common thing that I see in the clinic is what we call spinal deformity. The two main deformities that we deal with are one, scoliosis, and two, kyphosis. So scoliosis most people have heard of. It's where the spine is curved in the frontal plane, or when you look at the patient from the front. Kyphosis is when you look from the side, and that deformity is more commonly called a hunchback deformity. The deformed spine requires much larger surgeries, and the symptoms tend to be a little bit different. They tend to manifest not only as a combination of back pain and nerve pain, but dysfunction in standing and in the balance of the trunk relative to the pelvis. And the surgeries that we do for the deformity usually require bigger surgeries, more screws, longer rods, more time in the hospital, longer time in the brace. But these deformity correction surgeries can be life-changing for the better. And we have a lot of satisfied patients who have had deformity correction surgery, and they feel a tremendous amount of relief, not only in their posture, but in their ability to ambulate and do their activities of daily living. And we see a lot of them return to the activities that they enjoy. So it's a very satisfying procedure and can be a dramatic change for patients overnight. So those four things are what I typically see in my clinic. Other than that, we have a big team of spine surgeons here, and we deal with any type of spine problem that you may have, and we look forward to serving you. Please come give us a visit if you need to. Thank you.
Now it looks like we have some questions here that I'll answer. So first question, will my pain worsen to the point I'll be in a wheelchair or unable to walk? So it's a question I get quite a bit with patients understandably anxious or worried about symptoms that can be quite severe. The important thing to understand in the two cases that I've discussed today, facet pain or joint pain in the back and herniated disc causing nerve irritation pain that we call radicular pain, are not progressive or dangerous to the point where permanent disability is expected. These are conditions that are painful, but not generally dangerous or progressive neurologically. There are rare exceptions to this with symptoms we call red flag symptoms, including a rapid change in strength, difficulty with bowel or bladder function, and other potential changes that we discuss with you in more detail in clinic. But in the vast vast majority of cases, there is no dangerous or progressive neurologic involvement. Second question is physical therapy going to make me better? Now, this is an interesting question and really needs to be looked at from two perspectives. Is physical therapy going to make you better in the short term? Is it going to make you better in the long term? A common misunderstanding is that physical therapy will treat short-term painful symptoms. The goal of physical therapy is to not only strengthen the muscles that help stabilize the spine, but also to work on your movement patterns as part of a unit that I think of as the core, the lumbar spine, and the pelvic girdle together. Optimizing that movement is a long-term project that requires active work for you and can result in long-term improvement. Question number 3, how long is an interventional procedure going to last? The two specific procedures I discussed today both involve the use of steroid. For steroid into either the facet joint in the back for facet arthropathy, or in a transforaminal epidural steroid injection next to an irritated nerve, the goal is to obtain relief for approximately 3 to 6 months. In the case of a herniated disc, often resolution can occur in that time frame and pain may not return. In facetogenic pain, 3 to 6 months is considered a successful injection, and ongoing treatment may involve repeat injections as long as you're getting duration of symptom improvement in that range. If you start to get shorter term effects, it may be time to consider more aggressive or alternative treatment options.
Okay, it looks like there's some more questions for me this time. The first one is, Dr. VanderHeiden, do I need surgery? So I'm glad you asked this question. It's a pretty common question that I see when I visit with patients, and they wonder if they need surgery or not. And the vast majority of patients don't need surgery, but surgery is usually an option once you've made it through the conservative care and you've come to me for a consultation. And my job is to advise you on whether that's a good option or not. And typically patients decide to proceed with surgery when they have ongoing and life-limiting pain and their quality of life is suffering. When that occurs, they usually come to a point where they decide to move forward. We call that elective surgery, when the patient elects to go forward with surgery. But my job is to tell you if surgery is a good option or not, and I promise to be honest with you in that regard. The second question, it looks like someone's asking, what are the goals of spinal surgery? So I think we covered some of those goals during my previous discussion. But in a nutshell, there are 3 primary goals to every well-done spine surgery. Goal number 1 is to realign the spine. So some spinal problems don't require any realignment, but often they do. And our goal is to realign the spine and put it back into the normal anatomical alignment, and then keep it there. So that leads me to goal number 2, which is to stabilize the spine. When we have conditions like the slip that I described, or the spinal deformity that I described, we can realign the spine, but if it doesn't stay there, then we haven't accomplished stability. Ongoing instability tends to lead to pain, and through providing stability, we can alleviate pain. The stability is provided in the short term by the implants, so we call that instrumentation or fixation. Essentially the screws and the rods. That's the scaffolding that provides the immediate stability. The long-term stability is provided by the bony fusion, when the bone heals. As we all know, bone lasts a lifetime, and if the fusion is successful and the bone heals, that will last a lifetime. The last question here, it says, I've heard many horror stories about spine surgery. Is surgery really worth it? Can it be successful? Obviously, I have a biased opinion on this, but I've seen many patients benefit from surgery. And my belief is that if surgery is done for the right reasons and the goals of spine surgery are accomplished, then we will be successful for you. If there are any further questions, feel free to connect with us below. And if you'd like to schedule a consultation, please visit us at www.panoramaortho.com. Thanks.